We're live.
Oh, all right. Welcome, everybody. I was muted. Thank you for joining us again for the second meeting of the Maternal Health Access and Birthing Patient Safety Task Force. This is the second meeting of the legislatively mandated Maternal Health Task Force. And my name is Christina Alonso. I'm the Division Director of Pregnancy, Infancy, and Early Childhood at the Department of Public Health. And I will pass it over to David Seltz, my acting co-chair.
Hi, good afternoon, everyone, and welcome to this virtual meeting of the Maternal Health Access Task Force. It's great to be with you all today on this very hot day. Thank you for tuning in. I'm glad we had planned to do this virtually, and so that we can all be in our own AC bubbles or fan bubble, as it may be. But really excited to continue the work of this task force with all of you. And first, just to say thank you again for your commitment of time and energy to this work. This was a really important task force that was established in landmark maternal health legislation last year. And we're thrilled by this opportunity to be able to continue the momentum on work around improving maternal healthcare for all residents in Massachusetts. I also want to thank all of those of you who are on our live stream and tuning in. Thank you for your engagement in this work, and we continue to want to provide opportunities for you to be able to engage in and connect with us as this work of the task force continues. So, just to share a brief update at the top of this meeting, I did want to let you all know that Dr. Alicia McGregor, who is an HPC board member and had been designated by me as the co-chair of this task force, she's currently on a leave of absence, and so I'm stepping back into this role as co-chair. But we do expect her back later this fall, and so we'll loop back with her at that time. And I just did want to mention that her leadership and engagement in the early phases of this task force was really tremendous. I'm really, really grateful for her thought, attention, and expertise as we've been thinking about the scope of the research agenda connected to this task force, which we'll be spending the bulk of the meeting talking about today. Her input and feedback is well represented in the draft outline that we've proposed. And that really is going to be the main topic of discussion today, is talking about the design of the research work of this task force. There were very specific legislative mandates for this task force to look into data, both qualitative and quantitative, to understand the changing landscape of maternal health care in Massachusetts, and to be able to ultimately propose policy recommendations that will lead us towards a vision of a more coordinated and accessible healthcare system. So we're really excited to be able today to talk a little bit more in depth about what are some of those specific research questions that the legislature asked us to look into, how we might propose to answer them, and really look forward to getting your input and feedback and guidance at this still early stage of is an ambitious proposal of work for the task force. So that's really the bulk of the meeting today. But before we dive into that, we do have an order of business, which is to approve the minutes from our last maternal health task force meeting on April 2nd. So if you move to the next slide, you can see here what the motion and vote would be. And so first would ask if there is any comments, questions, amendments to the minutes that were circulated to the task force members. Seeing none, I'd love to accept a motion to approve the minutes.
I'll motion to approve the minutes.
Thank you. And I'll just need a second motion.
Second motion to approve the minutes.
Thank you. And because we're doing this virtually, I will have to do this by a roll call vote. So when I call your name, please just come off mute and respond with a yay or a nay or an abstain. All right, so we'll get started. Dr. Alonso,
Yay.
Nashira Barel,
Yay.
Dr. Osipoku,
Yay.
Dr. Price,
Yay.
Dr. Shields,
Yay.
Lee Simmons, are you
Yay.
here? Oh, hi,
Yes.
hi, Lee.
Hi.
Sorry. And Dr. Hung Tru.
Yay.
Thank you. Approval of the minutes passes. So, and here's all of your names. Thank you. Great. So, to kick off the discussion today, Dr. Alonso and I just wanted to talk a little bit about how we're thinking about scoping the work of this task force and this report. And we're going to invite on staff from the Health Policy Commission to really kind of walk through a pretty in-depth outline of the proposed work plan today for your discussion and input. But before we do that, on the next slide, just to share a little bit about how we envision the respective roles of the two agencies who are co-chairing this particular task force. So, one of the really exciting pieces of new legislation that passed earlier this year established for the first time in the Health Policy Commission a new Office of Health Resource Planning. This new Office of Health Resource Planning is tasked with developing, a statewide plan of all of the different types of healthcare services available in the Commonwealth, and really developing a plan that tries to understand the distribution of those services and how they may or may not be misaligned with the needs of patients and communities. This plan will be used by other state agencies, including the Department of Public Health, to help inform both, general policies, but also specifically policies through the Determination of Need program. It will inform policies at Mass Health and the Group Insurance Commission, and is really, around envisioning a healthcare system that has the right level of resources to meet patient needs, understanding those varying patient needs, and working towards a more equitable and accessible healthcare system. So this new office was just launched this year, and we've been staffing this up at the HPC, including elevating one of our current staff, Kara Vidal, who you'll hear from today, to be the director of this new Office of Health Resource Planning. And we just saw this incredible alignment between this concept of understanding kind of the range of access of services that and how they're distributed and how they match patient need to be so well aligned with the work of the Maternal Health Task Force, that we're planning to have this new office with the new staff and resources available to it really lead the HPC side of the work here, in terms of tackling many of the qualitative and quantitative research tasks of the task force. This is a great opportunity, one, to be able to leverage existing resources to be able to do this work, but in my mind, an opportunity for us to be able to pilot and really innovate and experiment about what are the methods that we're going to be using in doing things like evaluating patient need, evaluating what is needed in communities. And this is an incredible opportunity to kind of test pilot what will be the ongoing work of the Office of Health Resource Planning in other services and in other areas moving forward. So really excited for you all to be able to meet members of this new office today and to hear how we're thinking about leveraging that mandate to be able to support the work of the Maternal Health Task Force. We do plan to ourselves do, a lot of the research work. However, I also have set aside some funding in my budget, in the HPC budget, to support a vendor if we want to use a contractor to, in particular, help us support us in doing some qualitative work, where we might go out and talk to different members of the public or the system to help further inform and contextualize our work. So we'll talk a little bit more about that opportunity as well. I really think your input and guidance and feedback is so essential as we launch some of these research questions, and ultimately your leadership and input in how do we contextualize what we end up finding out? How do we interpret it? How do we frame it? And how do we use this information to build towards a vision of a better healthcare system? And so, really do want to build a pathway and a work plan here, where we're going to be engaging with members of this task force, on specific research pieces of relevance and importance, and really to use our future meetings to kind of build towards that ultimate report, with hopefully some really compelling policy recommendations included as well. Dr. Alonso, we'd love to turn it over to you for your thoughts on how we're planning to do this work and the role of the Department of Public Health.
Thank you, David. So as many of you know, the Department of Public Health has a series of reports that it's been issuing over the years, looking at different aspects of maternity care. So we really want to focus this report on being complementary of those reports. And that's really the careful task that we've been doing as we've been thinking about the outline and as we've been preparing for today's meeting. We're also at a really interesting opportunity in that we are early in the stages of implementing levels of maternal care into the maternity care system. So we have to think carefully about how can that program uplift access, quality, and equity and not hinder it further. So those are just two things that are really top of mind. And so within DPH, I think things to think about is both the immensity of resources that we have within and also the immensity of experience and just human knowledge that we have of the people that are in DPH that have accompanied a lot of both the processes of closing down, sadly, maternity units, but also just sort of monitoring the pulse on what's happening with providers and facilities. So I do just want to give a landscape of within DPH, which I know it's, for people external, both to DPH and just government in general, it can be really confusing because we're many departments, we're many divisions. It sometimes seems that we overlap, even with Health Policy Commission. So just want to give some clarity of who we are within DPH and who's going to be contributing to building out this report. So I'm going to start with the Bureau of Family Health and Nutrition, which is where I'm housed. And what we do is we do both research and data analysis, and we implement programs that address family health. And so within that, very specifically, I lead the division for pregnancy, infancy, and early childhood. So we're tasked with implementing programs that deal with pregnancy, birth, the postpartum, and up to 7 years old. And for example, I work very closely with Kristen Price because Pinquin sits within DPI. But we also work very closely with other folks that are here and also probably folks that are watching today. The other office that is going to be working very closely with us is the Office of Strategy and Implementation. And really, they are tasked with both networking and debriefing and connecting both with legislators and with programs on the ground. And so Stephanie Doyle, who's the director of that office, is working very closely with me on the outline of this program and also helping to sort of understand the landscape of what's available and what can we put at the disposal of this program. The other division within BFUN, of course, is the Division for Family Health Data and Analytics. Many of you will know their work because they prepare the maternal mortality report annually, but they also prepare the maternal morbidity report, and they have several projects that are monitoring issues around data, including PRAMs and other databases. I'm not going to go into the immensity of it, but we have a lot of databases and a lot of access to data. The big question is, what data do we want and how are we going to use it for this report? And then stepping a step back into the larger Department of Public Health, we have also the new Office of Healthcare Strategy and Planning. And what this office is looking into is really thinking about the healthcare workforce and the healthcare delivery capacity that our state has. So this office, for example, is creating dashboards around specific providers. So they're building out a dashboard for certified nurse midwives so that we can understand both who's coming into the profession, how long are they staying, why are they staying, what are their needs, and why are they leaving the profession. They're also preparing some work around doulas to understand the context of the profession. So that's another office that I think is really is going to be very critical to building this out. And they also bring a lot of experience just in accompanying and working with different hospital systems as they've either opened or closed maternity units. So there's a lot of sort of institutional knowledge in terms of the regulations. And I think that that too will give a lot of context to how is it that within the regulatory framework, can we better support the sustainability of maternity units? And with that, I mean both hospitals and birth centers. And we also are very aware that we need to consider the community. So community health centers that are providing prenatal and postpartum care, and other folks that are doing that, such as community midwives and other, allied health professionals. So this, I think one of the things that I've been thinking about, and David's team has done a really good job, I think, of articulating, is we have so much. And I think one of the things to think about today is how do we actually reel that in and keep this report down to a volume and a depth and an analysis that is relevant to where we are right now in the state, given everything that's going on, all of the national and local challenges that we're facing. So I also want you as task force members, as you think about the outline, not just to think about everything that you feel that's missing, but also what can we actually not add so that this doesn't become a 2,000-page document. So I know that we have a very careful tension between the two things. And it's something that we've really struggled with as we've gone back and forth with the outline. But we do know our legislative task is very, very clear. So we will continuously go back to that. So I will hand it back to you, David. Thank you, everybody.
Thank you, Dr. Alonso, and I'm so thrilled to be able to co-partner and co-chair this with you. I think the work of our agencies is so complementary in so many ways, and through this work, we'll only deepen and strengthen those areas of collaboration and coordination. I also want to just highlight that the fact that the makeup of this task force was just, really well thought out. All of you represent, a very, sometimes very different part of our healthcare system, a different role. And all of that was intentional by the legislature in thinking about what are the complementary voices, organizations, and perspectives that we want to have at the table in doing this work and continuing the momentum, as Chris said, on a lot of good work that's been happening in our state recently. So, we're also cognizant of you all have day jobs and other important responsibilities. So, as Chris said, also I think a balance that we're trying to strike here too, in terms of using your time as efficiently as possible. But always welcome your time, input, and partnership and collaboration. So I guess one other question I'll leave you with before we start diving into the report outline is also thinking about the areas that are of deepest interest to you, that you want to be sure that you're working with us and engaging with us, that you may have data and resources to contribute beyond what we've outlined here, that would be incredibly helpful as we continue this. So before with all of that as preamble and a little bit of how we're thinking about doing this work, before we turn to the work, is there any comments or questions that that task force members have at this stage? Great. Seeing none, I think we can get into the heart of the discussion today, which is really around where we're at right now in terms of thinking about a draft outline. And I've said it before and I'll say it again. We've been iterating on this, but we're still at an early stage. And so this is really the opportunity that we would love your input on. So I am now going to stop talking and am very happy to turn it over to Kara Vidal, who is, as I mentioned, the director of the Office of Health Resource Planning. She's joined by a number of other HPC staff who are going to be leading this work, who will also present on some of this. But Kara, I think you can take it away.
Wonderful. Thank you, David, and good afternoon, task force members. It's great to be here with you today. Want to thank you for the opportunity, as David said, for OHARP to get to support this important work and test out some of our methodology and our thinking and our data. As David mentioned, our charge is really to think about healthcare supply and capacity and access in the context of need. And so I just think that aligns so well with the task force's charge. We started here on this first slide with some of the language from the enabling statute, chapter 186 of the Acts of 2024. And I think sort of building on what David and Dr. Alonso were saying in their opening remarks, there is such a wealth of knowledge and expertise on this task force within the Department of Public Health and just within the activities that the state has been undertaking over the last several years in the maternal health space. I really liked how you said it, Dr. Alonso. There's so much data and there's really so many topics. It's really more a question of what do we want to focus on and where do we want to look? Because I think without some of that focusing, this group could probably be writing dozens of reports over years, as the department and the state generally has been doing. But luckily, I do think that the statutory charge of this task force is relatively focused. And this group is really being asked to study the availability of and access to services with a particular emphasis on closures. So just to reiterate these three key points on the left-hand side of the slide here, the task force shall study past essential service closures for inpatient maternity units and acute level birthing centers, and closures of community-based, office-based, and preventative maternal health care. The task force shall study patient quality and safety considerations of essential service closures of maternal care units, and demographic information on the patient populations whose access has been most affected by past closures or of current limitations on the availability of maternal care services. So in developing the outline that we're going to walk through today, our team really was trying to anchor to this statutory charge while also incorporating feedback and topics raised at the first meeting of this task force, as well as guidance from Drs. McGregor and Alonso. And we also are wanting to draw on the existing body of work that exists nationally in terms of looking at obstetric unit closures. So wanted to go to the literature as well and know what there already is known about potential drivers of closures and potential impacts of those closures. So those were the couple of different sources and concepts that we were trying to anchor to as we were developing this outline. But also, as David said up top, you really are an incredible group of experts. And so we're really looking forward to your insights and comments. And just know that I have my red pen ready. We'll be happily taking notes and crossing things out and adding and jotting in the margins as we go. So looking forward to your guidance and feedback. Okay. So on the next slide, we wanted to start with this outline so you could get a sense of the overall flow of the proposed report here. Throughout this presentation, we'll have a slide on each of these different chapters with additional detail, but I wanted to give you the high-level overview so you have a sense of the big picture. So we'll start with an introduction, and then we want to move into chapter 1, which is trying to provide an overview of births and birthing persons in the Commonwealth. And so that you can think of a little bit of like a need chapter. What are our number of births, our birth rate, how have those things been changing? How do they vary geographically, demographically, and over time? That's our thought on chapter 1. In chapter 2, we'll do sort of a similar high-level overview of supply and capacity, and that includes both facility supply as well as workforce supply. And similarly, want to be thinking about change and geographic and demographic variation as well. The third chapter is where we're proposing to do this deep dive on hospital maternity unit closures. And we're proposing to look from 2013 to 2024 here. We're really lucky in that the state has pretty good longitudinal data on hospital discharges and hospital characteristics itself. So we do think we'll be able to get about a decade's worth of closures covered under most of our analyses. And as I said, we'll go into more detail, but I did just want to highlight a little bit of what we're thinking here in chapter 3, which is that we want this section to do 3 main things. The first is that we want to look at these hospital unit closures individually. And that's really because we think that each of these closures is very unique. Just to sort of jog your memory, if you don't quite have the list of hospital closures memorized from 2013 to 2024, this includes the closure of North Adams Regional Hospital, so western part of the state, slightly more isolated, a full hospital closure, somewhat unexpected. It also includes, for example, the closure of Norwood Hospital due to a flood, which was relatively unexpected. The fire and resulting temporary closure of Signature Brockton, as well as what you may think of as maybe not more traditional closures, but at least sort of planned, anticipated closures of a single unit with some intentionality behind it in advance. And so, given how different these closures are, we really think that to sort of lump them all into one model and try to just pull out some key data patterns would be short-sighted and wouldn't give us as much of the nuance and complexity that we think we're looking at here. So in addition to doing those individual case studies, we then do want to look across those closures, and we want to look for patterns, specifically patterns regarding characteristics that may be associated with a closure that may have precipitated or influenced the closure, and then patterns in terms of impacts that the closure may have had on its community. We'll then go into chapter 4, which looks at closures specifically of birth centers and office-based care closures. Unfortunately, the data available to us here are just not as rich as what we have for hospitals. So in a little bit, Catherine Harrison will tell you about our planned approach for that section. And then finally, in chapter 5, we have policy recommendations. We have some initial proposed topics included on the slide here for your consideration, but of course are looking forward to your comments, and also want to acknowledge that as we're going through this process, doing the work and getting results, that what we're finding may shape what we think of as sort of key learnings and key areas for recommendation. And I should have said, feel free to stop me at any time. We have some specific discussion questions that we'd love feedback on later, but if I can clarify, or if you want to add in comments at any point, please feel free. Next slide, please. All right, so our slides now just go through each of those sections. The first one we have here is the introduction section. I won't belabor this slide. I think we all know what the introduction to a report generally looks like. But the one thing that we really wanted to acknowledge here is how much work is happening in the maternal health space in Massachusetts. There have been other commissions and task forces that have been looking at this topic broadly, a multitude of reports, both from those groups, from the HBC, from DPH, from across state government. There's obviously the omnibus legislation that passed last year, as well as a lot of activity from the administration and from providers and the community, and lots of cross-sector engagement and effort underway. So we really want to make sure that we're contextualizing this report properly. That's also some of the reason why I think the scope that you'll see laid out in this report is very focused, because there has been a lot of work and learning done on other topics as well. And so we're trying to make sure, as Dr. Alonso said, that this is sort of additive and not duplicative. All right, so we can, if you don't mind, head to the next slide. So chapter 1, here we want to, as I said, provide an overview of the births and birthing people in Massachusetts. We'll want to start here with a statewide look at some of these key factors listed on the slide, and then we'll examine trends over time. So big picture here, we want to know our count of births and our birth rate. How have those things been changing over time? Birth locations, so thinking here specifically about hospital at home versus other sites. You will want to think about patient risk profiles and how those may or may not be changing over time. So is our population getting, our birthing population in particular, getting older or younger? Are they at more or less risk for adverse outcomes based on, for example, maternal age or other comorbidities that they may have? And then we'll want to look at some variables that may reflect access and quality of care. So we'll want to look at prenatal care adequacy rates, C-section rates, induction rates, and then some outcome data as well. So preterm births, low birth weight, serious maternal morbidity, and mortality. Of course, wherever data allows us to, we will break those measures out by race, by ethnicity, by maternal age, and insurance type. If additional demographic variables are available to us, we will break those out as well. Those are the ones that I think are most commonly available in our birth certificate information and our hospital discharge database, which are two key sources of data here. We'll also want to do this geographically. So everything I just said sort of broken down by region of the state. And then finally, we'll want to provide a summary of existing data to the extent it's available on patient birthing preferences. So setting, staffing, care models, want to build on any work and knowledge that we have for Massachusetts residents there on what they're looking for. And I see some hands, so the last point I'll add before opening it up is just that most of this information, most if not all of it, is existing information that we are sort of compiling and summarizing and trying to, identify trends and patterns through, but it's not sort of new data collection that the HBC would be undertaking. Yes, questions?
Lee, go ahead.
Thanks. First of all, I just want to say appreciate the level of detail here and the opportunity to provide feedback on it. I think I have some comments throughout, but maybe just starting here and some of my comments generally throughout are going to speak mostly to workforce and financial considerations. But for this section in particular, I do think it would be helpful to have some information on the type of payer the patients have and the percentages of those, just to kind of, get at any financial issues and then others, systemic issues that might be causing some of these closures. And then if you allow me to back up one second, I totally appreciate not wanting to boil the ocean here. And also, I think since some of these issues are not unique to Massachusetts, I do think it would be helpful at the outset, at a very high level, nothing like super granular, but to discuss, how some of these trends are not unique to Massachusetts and that they are national trends. So I'll stop there for now. Thank you.
And I'll just say, completely agree with both of those points. And I didn't mention, but we are certainly planning to do things by payer type wherever the data allows us to. Thank you. Dr. Shields.
Yeah, hi, thanks. I also appreciate how you've broken this down. And I also want to appreciate that it's good to take as much that without having to recreate or create new data. But I think there's a piece missing here, and that's the sort of at least the immediate postpartum outpatient care part. We know that a significant amount of maternal morbidity and mortality happens after discharge from the hospital. And I just wonder if there's any available data around adequacy of sort of the handoffs, the access to care once you've been discharged and are having some of those symptoms we tell people to call about in terms of, the postpartum period, and where could we get some data on that? And then I would also echo the questions around insurance. And then I think language needs would be another potential demographic to include. So thank you.
Thank you. Okay, seeing no other hands at this point, we can move to the next slide, and I will hand it over to Dr. Sasha Albert.
Thank you so much. So Chapter 2 of the report proposes to look at maternity care supply and capacity in Massachusetts, including both facility and workforce factors. On the facility side, we aim to explore not only what maternal care facilities we have available, but also use of and access to those facilities. For instance, elements such as the geographic distribution of hospitals, NICUs, and maternity beds, staffed beds, and then also elements such as occupancy rates or drive times to hospitals, and other access factors such as quality or affordability. Because we know that geographic proximity to care is important, but also that access involves a lot more than simply having just a provider sort of located near where you live. So we'd like to try to get at those other dimensions, and we'd welcome any thoughts from task force members on relevant ways to capture sort of a more multidimensional picture of access to care. I also want to note that we included levels of maternal care in our report outline as an important dimension of supply and capacity. But as Dr. Alonso discussed at the opening of this meeting, the Commonwealth is currently in the process of assessing hospital levels of maternal care. So data isn't going to be available in time for use in this report. So I just wanted to note that we plan to address this concept, but we're not going to be able to do it analytically at this point. On the workforce side, we propose to explore the status of and trends in our maternity care workforce, most notably OBs and nurse midwives, and other providers as well as feasible in the data, looking at elements such as counts, demographics, and involvement in care over time. And we'd like to use non-quantitative approaches, relying on the research literature and meetings with stakeholders to learn about important challenges for our maternity care workforce, things like barriers to entry or difficulty that different roles may have staying in the field, and anything else that's important to know about our maternal care workforce in the Commonwealth. Yes, and I'm
Go ahead,
seeing
Lee.
some hands. Yeah.
Thanks. Again, I really appreciate this. I again, with my two kind of key points throughout the report, wonder if there should be a third section here specifically on financial sustainability, and maybe the whole chapter is mass maternity care supply capacity and sustainability. I think that piece really needs to be highlighted. It's something, that and the workforce piece is continually what we hear from hospitals, and really think that deserves and needs a deep dive in this section. I will also say maybe again highlighting my comments on the previous section. I think you've got the commercial relative price here, but I think having public payer mix and the extent to which the reimbursement does or does not meet costs would be important to look into too. I think kind of reflecting some of Dr. Shields' comments from the last section, I think it's important to not just think about the inpatient units themselves, particularly for pre and postpartum care, and thinking about access to outpatient services in these contexts. And then I would just note, very much agree on digging on the workforce piece, digging into OBs and CNMs. We also have heard from hospitals how much the availability of labor and delivery nurses affects their services, and so I think would make sure to dive deep into that piece as well. And then I don't know to what extent it makes sense to look at it here, but I know a lot of facilities are using locums, and so that might be important to understand the impact of that.
Thank you. That's very helpful. Yeah, completely. I mean, I was taking notes as you were speaking, and I completely agree about the importance of labor and delivery nurses. Well, I think we are, as always, limited by the contents and quality of available data, but I know that there's also a robust research literature on the sort of the importance of labor and delivery nurses and the sort of the limitations of not being able to adequately staff in that role. And if we can't measure it directly, we can speak to it in other ways.
We do collect some of that data from the hospitals in terms of vacancies. So that might be something we would be able to share. I think we have it for both labor and delivery nurses and for nurse midwives. We looked and we do not have it specifically for OBs. I think we have a larger like MD category, not an OB specific.
And Kara, I might just ask on you 1 second to share, sorry. Just to speak a little bit about, kind of financial status, financial stability, reimbursement. This is, I think, connected to the closures analysis that we're going to be doing, but I'd love for you to speak a little bit more about Lee's comment there.
Yes, happily. Thank you. So I think in terms of payer mix, yes, absolutely. We will definitely be looking into that. We can do that by hospital. We can look at that specifically for the hospitals that closed. We also have some data from the Health Policy Commission, not from our group, but from the HPC generally, on reimbursement levels by hospital. And I believe that's comparing commercial to Medicaid. And hopefully, I think that will be published before this report is. So we'll be able to incorporate a little bit of that as well, perhaps. On the question of sort of cost or profitability, we have given that some thought and are not recommending here trying to look at that analytically because it's very complicated. We obviously have access to the CHIA cost report data, which breaks out costs by different service lines. But having spoken with some of our economists here at the HBC and our expert consultants, there's just sort of a level of complication in interpreting that and some variation in how hospitals are able to allocate costs that give us some pause that we would be able to do that well in the time period that we have. So I certainly agree that that is a very important consideration. And I'm just hesitant to say that we would be able to do that, given that it's, our understanding is that there isn't necessarily like a well accepted methodology that we could sort of take off the shelf and apply to our data. I think it would take some time and iteration.
I think, Lee, one thing I would just add to that is we're thinking about, and we'll be talking about this a little bit later, an opportunity to go out and do some like stakeholder interviews, to do some, like targeted outreach. That may be a place where, that may be more a qualitative place where we're going and talking to hospital leadership and trying to understand from their perspective, what is driving that instability and being able to report on it.
Yeah, I appreciate that. I think it does need to be addressed in some manner in the report, whether through the qualitative pieces or even just explaining what Kara outlined, and maybe, just addressing why it wasn't included, and potentially recommending a further study if we think appropriate. And then, sorry, one other thing I'll ask that's related, or comment on that's related, is just wondering how not just rates, but payment methodologies affect outcomes. So, how are bundled payments affecting length of stay, appropriately or inappropriately, things like that. I think would also be important to think about.
Nishira?
Yeah, I think some of that was what I was going to say, so I'm glad that Lee went first. I wanted to just add, David, you mentioned talking to hospital leadership, and I would just add talking to birth center leadership as well. And there's only one open, but I think it's a really, really significant story to be told about the difference in facility fee between birth centers and hospitals, and how that is a major point of vulnerability for birth centers, and something that we're working really hard to address. So wanted to add that. And then I just wanted to, in the counts of OBs, CNMs, I think also, given that the legislation we just passed moves to license CPMs, I think a count of CPMs would feel really important here. And I'm curious what Dr. Alonso thinks about that.
Yes, just nodding enthusiastically. Yeah.
Yeah, I completely agree. I mean, I think the legislature has signaled the importance of the professional midwife workforce to the Commonwealth. I think, given that we're seeking to complete this report on such a fast timeline, we wouldn't be able to use, incoming licensure information, for instance, to measure our CPM workforce. So I think we want to make sure that we have an accurate count. So we would welcome any recommendations on the best way to make sure that we're reflecting them adequately and accurately in our report.
My assumption is the mass chapter of NACPM, but Chris and I can maybe check and see if there's another source for that.
Thank you.
Okay, I just wanted to go back to levels of maternal care, which is sort of a baby that I love. Even though the DPH is also trying to come out with the regs, we could get a sense of, because levels of maternal care is really an assessment of resources that are available to hospitals and patients for risk-appropriate care. So related to David saying we'll speak to some of the hospital leaders, we could get a sense of what resources are available to patients at certain places. So how many specialist physicians are there, in terms of how many MFMs may be there, or even MRI and reimaging services are available to patients in those interviews, just so we get a sense of how many people actually get access to sort of higher level acuity care based on where they are located. So it doesn't have to be the actual regs, but sort of a proxy to understand what resources are available to patients.
That's great. Thank you so much. Yeah, I don't think we had thought about approaching it from that angle. That's really helpful. Okay. Well, seeing no other hands, I'm going to hand the deck back to Kara for chapter 3.
Great, thank you. So here is where we are proposing to really get into the meat of the hospital closure, specifically the birth center and outpatient closures we'll talk about on the next slide. So as I said up top, part of what we used in informing ourselves in the development of this outline was a review of the literature. And there is some good literature nationally on hospital OB unit closures, looking both at factors that are associated with those closures or could potentially be called drivers of those closures, as well as the impacts of the closures on patient outcomes. I do want to say that the literature we've reviewed so far is somewhat mixed, especially on the impacts of closures. On the drivers of closures, there are a few things that come up regularly: volume that the unit is seeing, area staffing levels, so not necessarily staffing at the hospital itself, but sort of just the availability of the workforce generally. I think that's consistent with what we hear in Massachusetts too. And then area demographics too. There have been some studies that have shown that the income and racial demographics of an area may not necessarily lead to the closure, but can be associated with closure, so that patterns are different in terms of area demographics for hospitals where a maternity unit closes versus those that don't close. In terms of impacts of closures, the one thing that is consistent, unsurprisingly, is that when a hospital unit closes, drive times tend to increase. I think that's relatively obvious, and that is a consistent finding that we see. But other markers, I think we have seen a little bit of mixed evidence. We have seen some studies finding that prenatal care adequacy decreases after a closure, whether or not the actual presence of prenatal care providers changes. We have seen that in some cases, prenatal care adequacy levels have gone down. We've also seen a relatively recent working paper finding that there can be some modest but beneficial changes after a closure. So, for example, if a hospital that was lower quality or lower volume closes, or one that had a higher C-section rate or a higher induction rate closes, patients can sometimes then get care at other hospitals that have a lower C-section rate, a lower induction rate, higher quality overall, and that there can be some small but modest beneficial outcomes in those circumstances. You can imagine the opposite, of course, as well. If the hospitals that were closing were higher quality, low C-section rates, then the opposite impacts could certainly occur. And then we've also seen a paper that was looking at some serious negative impacts related to maternal and neonatal complications, morbidity, mortality, and that did find some negative effects of closures, although in that study that we were looking at, the effects were time limited. So they sort of see a negative impact on outcomes in the immediate period after closure, and then the effect sort of dissipates the farther out you get from the closure date. So I provide that background just to say that we have chosen some measures here in this section that we want to look at based on where the literature has pointed us to. But this is obviously another area where we're very eager for your thoughts on what else we might look at. Okay, so as I mentioned up top, we want to look at hospital closures between 2013 and 2024. And our idea would be to start with a summary of those closures. So what hospitals closed, how many beds, where were they located geographically, and what can we learn from the essential service closure filings with the Department of Public Health that these closures have in terms of reason for the closure. Then we'd like to undertake a case study of each closure and look at them individually. And there are a few reasons why we think a case study approach makes sense here. The first, as I was saying earlier, is that each of these closures really is unique in terms of the circumstances of the closure, the communities that the hospital served, and the potential impacts on patients. In some of the research I was describing for you, looking at hospital closures, they'll limit to rural hospitals, for example. We obviously can't do that. We are only looking at about 9 closures over this time period. And so because we don't want to further narrow our sample by looking only at, for example, rural hospitals or hospitals of a certain size, we want to start by looking at them individually so that we can capture that detail and that nuance. We also think it's valuable to do this from a case study perspective so that as we're looking forward to policy recommendations, those can be informed by a good understanding of what occurred in detail. If you think, for example, about, again, the Norwood and the Brockton closures, the flood and the fire, unexpected acts of nature sort of situation, we wouldn't necessarily want to have aggregated all of those closures up, run the data in one model, and found maybe a relationship driven in part by Norwood and Brockton that actually, might not have intended to close the unit at all, right? So we want to make sure that the policy recommendations are addressing actual barriers to operation or issues that are impacting hospitals and not patterns that we might find if we were to just sort of look at everything in a statistical model. And then finally, we just don't have enough closures to really rely on having statistical confidence in throwing everything into one big model. A lot of the literature that we've looked at is looking over multiple decades, the entire United States. They often have a big enough sample to be able to do this as a statistical model. So our thought here is to start with a case study, look individually, see what we find descriptively, and then if we're starting to identify patterns, that doesn't preclude us from necessarily going in and then trying to use a more sophisticated model once we have a sense of what those key variables are. But we think it's going to be informative to look individually first. Dr. True.
Hi, thank you, Kara, and thank you for the whole team. It's been great to listen and see what so much work's been put in this outline. I have a question in terms for the hospital statistics under the case study. In terms of financial performance, are you thinking about doing it at the hospital level, at the unit level? And to what extent would you be also looking at, even if it's a case study or even comparing across the system of different maternity ward, how much are the deliveries actually being, like, what is the average price for the delivery or at that system or at that unit? Wondering whether or not that could also add to your assessment, right? Of kind of like, is it really unprofitable? Are they really getting less than everybody else in terms of so just a thought.
Yeah, thank you. That's a great question. So in terms of the financials, our thought as proposed here is to look at the hospital level and the system level. I think we'd like to understand individual hospital performance. If a hospital is part of a system, we might want to consider looking at the system level performance at all. But again, in terms of the maternity unit, as we were saying previously, we weren't intending to try and look at the profitability of individual units just because of some of the methodological challenges that I was highlighting. Whether or not we could do the actual price, average price, or average reimbursement for a delivery, our research and cost trends team has been able to do some of that work in more recent data. We would have to go back and talk with them about whether they have the data to do that historically. Because some of these closures happened as far back as 2014, I don't know that we would necessarily be able to get, an accurate picture of the reimbursement level at that time. But that is probably a question for our senior analytics manager and some of the folks on the research and cost trends team. Shiva?
Thanks. I have a kind of a thought I'm chewing on. One is about the facility fee for hospital-owned birth centers and just understanding those hospital birth centers, North Shore and Cambridge, that closed and cited often financial instability. If that birth center had the same facility, could a hospital level facility fee is a question. And then I guess sort of related to that, maybe more so North Shore, but Cambridge also, like, there's been a lot of community response and pushback to the closures. And I guess I'm wondering, as part of the case study, in maybe like a qualitative way, like, what is some of the story and the perception around that? Yeah, I guess I'm thinking about, like, there's a perception that hospital leadership doesn't support the midwifery model of care. And so, like, is there something there? Is there something to be countered about that, where this actually can say, well, this really was financial, and therefore, the answer is in improving reimbursement rates, and also ensuring that hospital leadership, understands the crisis of maternal health and the role of midwives and that. So I don't know what's there. I'm just kind of chewing on a little bit of, like, there's a story in all of these closures, and that I think is a little bit beyond the hospital statistics and maybe it's what you have under circumstances of closure, but community perception, something there. I can chew more on it.
We do have a slide at the end of this presentation specifically on qualitative research and where it would be most beneficial to use some resources to try to talk to, whether that's patients or community members or providers or administrators, et cetera. So we would really welcome some thoughts on where, especially in this outline, we feel like we just need more fleshed out information and where that qualitative perspective would be helpful. So definitely keep chewing. Okay, so to tell you a little bit about what we're envisioning in each of these case studies, we've already started to talk about some of these measures, but first we just want to give a few high-level statistics about the hospital itself. So what type of hospital is it? Is it an AMC, a teaching hospital, a community hospital? Is it part of a system, or is it independent? We've talked already a little bit about financial performance, payer mix, which I didn't have on the previous slide, but yes, absolutely, definitely want to understand payer mix, relative pricing levels, and volume overall. Then we want to look at the maternity unit specifically. So again, size in terms of number of beds, the volume, how many births are there in a year? Can we use those things together to calculate an occupancy rate? That's something our team has been looking into. We also want to understand who the hospital was serving, both geographically, what surrounding towns and communities make up its primary service area, and in terms of demographics. So how are the patients of the hospital in terms of race, ethnicity, age, insurance type? Again, those are, I think, the variables we most commonly have in our data sets, but if we have other demographic information, we'll include what we have. And we want to look at that sort of two ways. First, we just want to look overall and have that picture, but we also want to look at it in terms of representativeness. How representative of its community was this hospital? And some of you may be familiar with the Lown Racial Inclusivity Index. And that is a concept that they've put out. We've also put out similar concepts in past HPC work as well. And that idea is basically to look at the demographics of the service area and then compare the hospital's patients to that overall community. And so we would propose to do that certainly on a race and ethnicity basis, as well as on an insurance basis. So, basically you can say if the hospital service area of all their births, 8% of them were to Black birthing patients, is the hospital also approximately 8%, or are they more, or are they less? We also want to look at how the hospital performed on maternity quality measures. So Sasha raised this idea on the last slide of the presence of the unit is of course important, but how it performs is important as well. So what can we say about quality measure performance? There are some wonderful, really helpful quality measure data from Leapfrog. I don't know yet quite how far back the Leapfrog data go. And so what we'll be able to do here specifically is going to depend on data sources. If people are familiar with maternity quality measures specifically that are publicly available and that go back, many years, we're happy to take that information and incorporate it and hopefully we're hoping that at least some of those measures will have enough years of data that we can look at that for some of the older closures. Then the circumstances of the closure. So here we'll really be mining from the essential service closure filing. So what type of closure? Was it the whole hospital, or was it the unit only? When did the closure occur? What did the hospital describe as the reasons for the closure in that filing? And then we want to look at the impacts of the closure. And as I said, we want to start just by doing sort of a pre-post descriptive level impacts assessment here on a couple of these measures that, again, we've seen in the research literature as being likely to be impacted. So that can be drive times, low risk C-section rates, induction rates, serious maternal morbidity, and prenatal care adequacy. Once we have looked individually, we'll want to start looking across the cohort to see if any patterns are starting to emerge, whether in the hospital or maternity unit statistics section. So those would be potentially factors that we might think explained or partially why the closure occurred, or in the impact section. And if we are starting to see patterns, we'd like to, of course, describe those, call those out, perhaps see if we could do some more robust statistical testing of those patterns to really see if they hold up. And we also want to look at where patients go for maternity care after a hospital closure. And so questions there mostly about whether patients are choosing the next closest hospital or another hospital in the same system, and if we see differences by race, ethnicity, or age. As part of this, sort of looking across the closures, identifying patterns, seeing if there are variables that are sticking out. If we are starting to see patterns, we could potentially use that to identify other hospitals that could be at risk of closure and identify those to you. But we'll have to sort of wait, I think, until we start to see the data and see if those patterns are emerging or not. Yes, Dr. Jones.
Yeah, hi. I wanted to go back to the question about it's listed in a different way in the handout that you sent us ahead of time, but this issue of looking at SMM risk or OB risk, have we chosen a specific measure to use, like a specific scale or specific tool yet for that? Because there's multiple different ways to assess that, and some of them count more of the social demographic stuff and some of them count more of the medical issues, and I just wondered which one we're going to choose for that.
So the index that we had been looking at is out of California, and I do believe it was based on maternal the California Maternal Quality Care Collaborative Index, if you're familiar with it, which is mostly maternal age and comorbidities. If there is another index that is preferred, we're happy to look into that and see if we would have, the right data points to be able to measure it accurately.
I'm gonna hope that someone else jumps in here with that, but I can certainly ask around about other ones because I do think there's others that take into account more like something called social vulnerability or the issues around the income and economic status and educational language barriers, all those things, which I think are also an important thing to look at.
We could certainly, so we have seen indices of that type that aren't necessarily specific to obstetric risk, but just sort of general social risk. So we could try to incorporate those. Generally, those we could use to describe the population in the hospital service area, but not necessarily the population specifically that the hospital treats, just because they tend to have those measures at a zip code level rather than an individual level. So we wouldn't be able to sort of compare and say, well, the social vulnerability index for the area is 1.4, but this hospital's was 1.8, just because we don't have individual level detail. But we could probably incorporate sort of a general social vulnerability index for the hospital's service area.
Yeah, I just wanted to, and I don't know if it's here or maybe in the previous section, but, and I know you're going to be looking at volume metrics, but, we hear a lot around how volume affects quality. And so, perhaps, yeah, again, I'm not sure if that's on looking at it in the case study piece or in the previous section, potentially.
Mm-hmm.
And then the other thing is, I don't know if this is the right point to bring it up, but on the line you sent via email, the kind of discussion of key themes piece talks about potentially discussing reimbursement issues, and would just at the risk of sounding like a broken record, definitely think that needs to be included for sure, and not just a potential piece.
Thank you. All right, seeing no other hands, let me turn it over to Catherine Harrison to take us through the next couple of slides.
Wonderful, thanks, Kara. So as you just heard, Chapter 3 will focus on the drivers and the impacts of closures of hospital maternity units. And in this next chapter of the report, what we're proposing is to look at additional types of maternity care, both providers and settings. So specifically birth centers and prenatal and postpartum care in office settings. As Kara mentioned a little while ago, on the birth center piece, we're expecting that analysis will rely more on qualitative research. Our sources of information and quantitative data for the hospital analyses just don't include birth centers. So our intention here is to draw more on secondary sources, both to help us identify closures and to give more insights on some of the drivers of closures. So there's a lot in the literature already that we know from DPH and other sources on, that will help us identify the closures and give us some basic factual information about when they occurred, the circumstances around that closure, et cetera. In addition, there is good literature that we're beginning to look at that talk about the financial and other barriers associated with operating birth centers. And we would want to describe some of those factors in this chapter. So, it's already come up today. Some of these barriers around reimbursement, the facility fee that a birth center can command versus a hospital, costs associated with facility acquisition, malpractice insurance, staffing. So we would be looking to sources of information about some of these factors behind birth center operations, and look to describe some of those generally in this chapter, as well as potentially to, as Kara alluded to, speak with some of the individuals who were involved in some of those closures that have occurred here in Massachusetts, to understand some of the factors behind those closures. It's worth mentioning too, I think in this chapter, we will want to give some information about the work that has been done recently in Massachusetts around reducing some of the regulatory barriers to birth centers, including, key provisions of recent legislation, establishing the Board of Midwifery, new DPH regulations that have just been issued in the past few months that have addressed some issues around facility requirements, leadership qualifications, staffing, CPMs, et cetera. And also, understanding that Mass Health has recently taken steps toward payment parity for services delivered by certified nurse midwives. But we will try to look at what we can see about what were some of the drivers of the closures that have occurred, and think about the prospects for birth centers going forward, including both some of the improvements that may have been made through those and other recent changes and reforms, as well as barriers that may remain, whether those are around reimbursement, staffing, startup costs, or other things. And this is certainly an area where we know folks on the task force, Nashir and others, have a lot of expertise, and we would really appreciate and look to task force members for guidance and input, pointing us in the right direction on where to look for some of the most important factors in Massachusetts, and really tapping into your expertise and information would be really valuable here. On the topic of office-based closures, and particularly prenatal and postpartum services, again, we face some limitations to our data sources when it comes to assessing changes in the supply and capacity of individual OBGYN and other maternity care providers over time. We are working on one more quantitative approach to this, using data from the HPC's Registration of Provider Organizations program, which does capture information on healthcare practice locations and provider headcounts across the state. So we're looking at doing an analysis that would track the change in the number of OBGYN providers over time by region. And this would, while not perhaps giving us a full sense of capacity, given that it doesn't necessarily speak to information about, sort of the total capacity of providers from the standpoint of, how many hours they're seeing patients, for example. It would likely give us at least some directional indication of how the supply of prenatal and postpartum services by that particular provider type over time has changed in different parts of the state. And again, as with the birth center closures, our plan would be to explore this topic qualitatively, in addition to that analysis that I just mentioned, through existing literature and reports, and again, would welcome task force member suggestions for other resources on this subject. Questions or comments? Yes, please, Dr. Shields.
Hi, thank you so much. I think this is a trickier area to assess. And I'm gonna be a little bit of a broken record here from the previous meeting, but just to remind us that family physicians and other providers do some of this outpatient care and wouldn't necessarily be counted in anything that's defining people who do maternity care only as obstetricians. So obviously also nurse midwives, but nurse practitioners, physician's assistants do some of this care as well. So I think one of the more recent reports from from the state had looked at access in around the Barry area and totally neglected the fact that the Barry Family Health Center has providers that do maternity care. So I just want to be, remind us to be cautious about this issue. So thanks.
Thank you. Very important.
Can I ask a question on that piece? The RPO, Registration of Provider Organizations data set that we're proposing to use here does only have physicians. So we can, we could certainly caveat, potentially we could think if there are other sources, but it would have family physicians. My understanding is that not all family physicians necessarily provide that care. Would you recommend that we include or exclude? I don't think we'll have, enough information to be able to accurately include only those who perform deliveries.
Yeah, that's a great question. I'm gonna try to pull on my sources at the Mass Academy of Family Physicians to kind of help try to answer some of that. But if we have any data about numbers of family docs who do the different parts of the perinatal care, I guess I would just say at the very least to include a comment that, we know there exists the capacity for this kind of, particularly this outpatient immediate postpartum. People may decide to access the neighborhood health center that's 2 blocks away, that's going to be staffed that day by a physician's assistant or a family doc who doesn't necessarily do intrapartum care, but may be able to be trained up to recognize early warning signs or whatever it is we want to work on in that peripartum period. So.
Thank you.
I'll perhaps just offer an observation as we've been having this discussion. I think one of our challenges here is that, as Kara has said, some of our richest and most robust data is the facility-based data. And Dr. Alonso, as you said so eloquently at the start of our last meeting, so much of this care is in the community. And having a community orientation to how we think about prenatal, postnatal, all of the different settings of care that patients are connected to and where they're receiving care, where they're making decisions is, in the community. And so I raise that just as something that we're going to continue to wrestle through and really encourage your creative thinking with us to make sure that we're striking a right balance in terms of what this report looks like and not having it and helping it as much as we can be able to examine the kind of the full spectrum of care. And maybe just a quick question for you, Kara and Catherine. Understanding we may not have that same level of information on the kind of freestanding birth centers, where there is a birth center attached to a hospital, are they kind of reporting at the same level of depth up through the hospital? And can we actually differentiate between the birth center births and the kind of main campus hospital births in those circumstances?
I think where we landed on this is that being attached to a hospital actually may make it harder to see the birth center patients, because if they're billed as part of the hospital billing, it can be harder to identify them. If there were a freestanding birth center, we might be able to observe that in our claims-based data, assuming we had the right payer in the all-payer claims database. But I think the trouble with the hospital-based birth centers is that they can be harder to distinguish.
And thank you, Dr. Osipuku, for mentioning the all-payer claims database. That's something we're also, really exploring, because that does allow us to obviously go beyond just the hospital setting of care. Lee?
I just wanted to suggest on the pieces around resources in the community that it might make sense to ask the Mass League of Community Health Centers if they have any insight on how to capture that.
Great suggestion.
Thank you so much. All right. Well, On the next slide, we're teeing up what we think may be some of the topics to address in policy recommendations. And I think this is the last section of the report before we can have a more general conversation about how this feels and get more of your input. But we did want to offer just some at least preliminary thoughts on the kinds of topics that we might anticipate speaking to in the policy recommendations section of this report. Obviously, as been said, it's a bit early to know for sure, what our findings will come up with and where we'll want to focus. But we know how important it is to this task force that this report moves beyond just documenting problems to actually being actionable. So we certainly wanted to put some potential themes and areas for recommendations on the table for you now so that you can begin to react and help us shape the direction of the report overall. So at this stage, the kinds of policy recommendations that we're thinking about, I think really focus both on things that can be done to both prevent and mitigate the harms of maternity care closures and loss of access. So to start with, through the hospital-based analysis that Kara described, we may be able to identify some patterns that we can put forward as a framework for spotting hospitals whose maternity units may be at risk of closure. So we may even be able to say something about hospitals that appear to be particularly critical sites of care, given their geographic location, their quality performance, the population they're serving, or other important factors, and thereby spur a policy conversation that's more focused on preventing closures than reactions to closures after the fact. Similarly, we may be able to talk about how the tools of health planning could be applied to help prevent certain closures. One of the things that we know and has come up already today is the importance of volume to sustain maternity units, having a sufficient number of births. And we may be able to think about how concentrating resources more centrally could help reduce the number of unplanned closures in a given region, for example. Based on the findings of our analysis on the impacts of closures, we might also want to make some policy recommendations on mitigating the negative impacts through better or more comprehensive planning prior to the closure. These could be recommendations on things that hospitals and other sites of care could do to better support patients in their catchment area to transition to other sources of care, and potentially how maternity units that are on the brink of closure could work with other local providers to support those transitions differently and more effectively. Moving through this list here, we might also think about whether there are new or enhanced regulatory authorities needed to ensure significant or sufficient planning or mitigation of potential negative impacts in the event of maternity care closures, whether that's through enhancements to DPH's essential service closures process or other new requirements. And we certainly may have some recommendations related to enhancing and supporting the workforce. Not only to ensure adequacy in the sites of care, but also to make sure that there's a diverse array of professionals available to provide care in all of the both facility and community-based settings that patients want and need. And obviously, through many of these recommendations, we expect to encounter themes around the need for payment reform and reductions in the financial barriers to a more robust maternity care system. Finally, obviously, at the end of policy recommendations, there is frequently an opportunity to cite or to raise questions that might deserve further study. And we would certainly leave room to do that here to address things that might be important, outstanding questions, but that the task force has recognized are outside of the scope for this particular report. So I'll pause there and be happy to hear reactions to this list. Obvious things that you would like to be able to talk about in the policy recommendations section that you don't see here, or other thoughts about these initial ideas. Yes.
was waiting to see. I feel like I'm taking a lot of airspace here, so I was waiting to see if others are going to jump in. But I think most of these make sense in terms of potential areas to make recommendations on. I do just want to raise some concerns, I guess, around the emphasis on using processes that come into place after many years of trying to keep units open. When I guess I should take a step back and say that what we hear from hospitals that have had to close some of these units is they've tried many ways to address many issues, workforce, finances, the list, volume, the list goes on, to keep their units open, have tried several different initiatives, and that they just have not been able to make it work after multiple years of trying multiple things. And so I worry that emphasizing changes to the essential services closure process, or preventing, or anything that like prevents or prohibits is just too late to really have an effect. And so I think instead I would prefer to see in the recommendations an emphasis on maybe, rather than saying preventing closures, ensuring supports of hospitals at risk of closure instead, and then really making more robust the workforce supports, workforce innovations, reimbursements, and financial reforms and innovations to make sure that we don't get to the position where closure is imminent. Because I think the way the system is designed, and I don't think our recommendations would change that, frankly, is that it's just too late by the time it reaches that point. And so I think it would be much better to emphasize the recommendations that are more upstream, to ensure their sustainability.
Understood. Yeah, as you were speaking, I was just thinking of that word myself, upstream factors that are a little bit ahead of where before a unit is in dire straits. So yeah, thank you for that comment.
Dr. Shields.
Yeah, I was sort of thinking of the analogy with the too big to fail type of approach. Like, what is there a way to develop like a stress test measure that would look at those upstream factors and try to find out, who's getting into trouble, and then, speaking to what Lee's saying, like, have some ways to look at preventing it getting further down the stress test path. Sort of maybe that's what's already happening. I don't know about that, but like, is that something that could be more formalized or structured with the support needed along the way?
Yeah, I think that reminds me of some of the work that we are hoping to do in chapter 3, to sort of both look at these closures individually, but also sort of to try to spot patterns. And that I think may be the place where we can explore that very question of are there obvious patterns that emerge about the factors that are associated with closure, or what's going on in the immediate, or maybe not so immediate time around the closure. But that's an interesting thought about sort of a stress test, and Kara, jump in here if you have additional reactions, obviously.
Just that we certainly know that concept exists for sort of hospital financials at a hospital level. So I agree. I like the idea of trying to do something specific for a maternity unit, and whether or not we see the pattern sufficient to allow us to try to do that, we'll just have to wait and see.
Go ahead, Lee. Thank you.
I think hopefully just one last thought for me. I know to the extent, in particular, if these recommendations start or are addressing, clinical changes or clinical practice. I know I've mentioned offline to folks, and I think others have raised it too. Of course, we don't have OBs or nurse midwives on the task force, and so I think it would be helpful especially if we are getting into clinical recommendations, to make sure we're including those voices in the recommendations.
Thank you, Lee. And thank you for your comment. I really do think thinking, at different stages of what are the supports needed, how do we create an overall environment where, we're supporting the delivery of high quality maternal care that meets patient preferences through changes in reimbursement, through workforce supports. I mean, to me, those are like, essential, like foundational points. And then even thinking about something like a stress test or places that are at risk, how can we then mobilize state resources quickly to be able to provide that level of support before it gets to kind of that next level of danger, right? Because, and I think this is again maybe more of my personal comment, but when it gets to the time where a hospital is announcing a closure, there's not much you can do. I mean, it becomes almost a self-fulfilling prophecy at that point in terms of that announcement. So how can we really back that up further in the process and marshal state resources to not be reactive after the facts, or to just have to rely on transition planning, which, there may be some opportunities to improve that, but it's almost too late at that stage. I think another reflection I'll just share with the team here is, some of this is around the supports needed to maintain our current, levels of access. But I think we should also be thinking about recommendations that go beyond that and thinking about where there are areas of unmet need, and that we want more birth centers. And so it's not just about kind of preventing closures of the things we have, but really about expanding access in areas where there is opportunities for unmet need, and workforce and facilities outside of the hospital, I think go to that.
Thank you so much. All right, I think the last two slides in this section of the deck really are a continuation of the conversation we've been having about getting your input. So there are some discussion questions here, and then one more slide that drills down a little bit further on some of the feedback that we'd love to get from you on the qualitative research. So I'm happy to pause here. I think David and Dr. Alonso, if you'd like to moderate some conversation on these topics, or I'm happy to do so, that's fine.
I think we've been having some discussion all along here. I think with our remaining time, let's talk about the qualitative piece, because this is another topic.
Right. All right. So we are, as I've said, particularly interested in hearing from the task force about your priorities for qualitative research to support this report. And particularly, I think we have the opportunity to do some novel data collection versus areas where there are also, a lot of existing reports and literature that we can draw on about some of the important themes that we expect to address in the report. So what we've got on this slide is a little bit of a set of options, or like a mix and match across some categories, and some questions for discussion. But sort of as a reminder, there are a number of places in the report outline and in the discussion we've had today where any of the individuals listed here in the perspectives box could be important sources of new information and in particular, people that or groups that we might want to do some new data collection in the form of interviews. And we could interview and talk to any of the people in that box on any of the topics listed in the middle bucket or others that have come up. So things like the factors that drive closures, the impacts of closures on patients, providers, the surrounding community. We can talk to people about policy recommendations or things they'd like to see to change to address closures before they happen or mitigate the impacts of closures. And I think we're also particularly interested in input from you all on the value of going deep with our qualitative research and focusing on perhaps a small number of case studies where we might interview many different folks in the perspectives bucket on a variety of different topics, but really get a comprehensive sense of what has gone on or what are the access challenges or the effects or drivers of closures in a particular circumstance, versus perhaps looking more deeply at a single topic and limiting our interviews to a particular group of individuals, but doing them kind of across the whole spectrum of areas and closures that we've seen. So some of the options that we have laid out in the outline include interviewing providers who remained providing maternity care in a given area in the aftermath of a closure, about the impacts of the closure on them, their patients, the community. We could interview leaders, hospital administrative leaders who were involved in closure decisions about the drivers of closures. We could interview leaders at hospitals that may be at risk of closure, if we're able to identify them and get a sense of the factors that are affecting them in that given moment. We've talked about interviewing leaders at birth centers about the challenges to operating birth centers and the drivers of closures that have occurred, barriers to entry. So there's a variety of different options that we've put on the table, and I think it would be very helpful to have some more conversation now about what you see as potentially the most valuable, and how we can both use existing sources of data on some of these topics or some of these perspectives, and where really new data collection and research might be the most valuable.
I can jump in. I think one of the questions that came up as we were thinking about the research, the qualitative research, was who can we get honest answers from that go beyond the reports? And so to some of the points that have been brought up today, thinking about, for example, Nashira's question of, how do we actually feel about the midwifery model of care and low risk non-surgical maternity care units? There's a public answer and there's a private answer to that. How do we feel about, to Sarah's points, integrating non-OBs as primary, as sort of those who are primarily responsible? So I think there's kind of layers of sensitivity around this, and given the time constraints, thinking about who or what would we ask that would contribute some new information that would really be beneficial to this. And I think the qualitative work that a lot of researchers have done from the perspective of midwifery or obstetrics and family physician, there's a lot of qualitative literature on the tensions between the professions and the tensions on the models. we've also kind of thought about how could we ask CFOs, like, so what exactly is your financial call on closing a midwifery, a maternity unit? And we're also concerned that outside of the public report that they published, we'd be concerned about getting anything a little deeper than that. So if there's any collective wisdom or thinking around what is it that hasn't been answered already in qualitative research or reports that we think would be really interesting or really instructive in understanding what's going on. So maybe that'll juggle your mind a little bit.
Well, Chris, I was going to jump in because so I love that in the perspectives you included other area providers such as EMS, because in the work that we're doing around levels of maternal care, I've just been blown away by the amount of knowledge and the expertise they have. And they're the ones taking people either from their home because there is no hospital nearby to the closest, which could be miles away, but they also are understanding the capabilities of different hospitals. The other piece that I would add maybe in that bucket is ED providers, because as we see these hospital closures, we're seeing more and more people showing up to EDs to deliver their babies. And so I think that might be a really interesting perspective as well, to get those perspectives. Right? Just said perspective twice, but you know what I mean.
Thank you. Mm-hmm. Yeah, I think that's exactly what we had in mind when we were thinking about other area providers, sort of this idea of a blast radius. Once there's been a closure, what are the ripple effects on other providers of care and potentially other sources of support in the community for birthing people. I mean, really open to different ideas here about how to explore that story that could either round out individual case studies or be used as a way of more sort of at a summary level, rounding out the report's information on how closures affect the landscape around them.
And then can I just add one more thing about the approaches? There is something to be said about looking at all of them individually, but the single topic spanning the deep dive on 2 or 3 closures, I just feel like there are some like Brockton and Norwood where it was sort of a natural disaster or something that was unforeseen that forced a closure, versus others where it truly was they couldn't sustain their maternity ward. And I think those are very 2 distinct problems. I do think though, for like a Brockton and a Norwood, what could be interesting is what's preventing them from reopening? Like, or is there a decision being made about, is this even worth that we bring back our maternity care after an unforeseen event? So I feel like there's almost 2 questions: those that like couldn't sustain the maternity ward and what really impacted that, and those that for unforeseen circumstances closed, but now are they struggling to bring those services back?
Mm-hmm.
Would agree with those points and would add on the fire and flood front, the Compass medical closure kind of at the same time also contributed to a lot of patients going to other facilities in that southeast area. And so think kind of transitioning to the larger question, talking not to area EDs about the effect in area community-based providers, but also area labor and delivery units that saw, literally overnight significant increases, and how that and what the effect of that was. I also do think to the earlier question around, I think it was Dr. Alonso's question around who to talk to. I do think speaking to the facilities with planned closures would be helpful, not just the financial pieces of it, but to better understand, to your point around what would be new, I think better understanding the different initiatives that were undertaken prior to closure would be helpful to learn more about why they didn't work and the barriers, not just the financial piece, but the workforce piece too. And then just one last point on the EMS point, I totally agree, and also think we've heard from some air ambulance providers, particularly for when air ambulance is needed, about they have a lot of thoughts too. So I think when we're talking about EMS, should also include air ambulance. Thanks.
Thank you.
Hung?
I just have a question about, I know that we want to focus on closures and, how to prevent it, but would there be any thought about, can we look at places that are very successful in terms of like, what are the lessons learned from a maternity ward that's doing really well? Does that exist in the state for the aspect of recommendations? Sorry to throw a wrench into this, but just curious about that.
I was having the same thought as Lee was speaking, that some hospitals may have tried something and still wound up with a closure, and other hospitals may have tried something and avoided a closure. So I agree. I think that would be a really interesting way to come at it, is less about the fact of the closure and more about what works and what doesn't.
Well, we're approaching the end of our 2-hour meeting here, and really just want to express my appreciation and gratitude for this conversation today. I've certainly learned a lot, and I'm so grateful to be on this task force with all of you. You've given us a lot of feedback and thoughts. I think we'll reflect on that and may follow up with some additional questions to you individually as we think through some of the modifications that we want to make to our overall approach here. But just to close out the meeting here today, just want to remind all of the task force members and the public that we are maintaining a web page with a lot of information about the work of the Maternal Health Task Force, and included in that, we've also got a resource library section where we've been putting up resources of related work. If there are submissions that you'd like to draw our attention to add to the growing body of information on our website, please feel free to reach out to the either Jasmine or to the MHTF email, and we'll collate and support those. I think in terms of next steps, we really are going to be thinking about reaching out to you members individually and going a little bit deeper on some of the conversation we just had today. Many of you made an offer to help connect us with information, or to go back to your organization and think about, is there additional resources or connections or collaborations that you can offer. So we're going to be reaching out to you individually, and then also if there is kind of a group of you that we want to talk to, recognizing our open meeting law requirements, that we can identify those people and have those conversations. And then we'll be in touch in terms of scheduling updated the task force meetings for probably the rest of the calendar year. We started this with a goal of being able to try to get a report done by the end of the calendar year. I think that continues to be an ambitious goal, but one that I want to try to hold us to as much as possible. I think it would be valuable for our report to be released with some time left in the legislative session, if there are areas that we identify that would be particularly helped by some legislative changes. So that is always in the back of my mind. But I'll turn it over to Dr. Alonso for closing remarks, and we can let you all go.
Thank you so much, David, and all of the team at HPC for all of your logistical organizing and your careful preparation of this meeting. It's just such a joy to work with you. And just as David said, I think we're all learning so much. So thank you for getting us to where we are today. And thank you to the task force members. We know that this is a big lift and it's a big ask, but we also hope that you're bringing everything that you know, and that, you know, your experiences and your wisdom and everything that you fight for every day is going to be part of this report. So thanks for being a part of this. We need you, you're important. And let's keep going. And I look forward to reviewing the notes from today, and we'll come back with a detailed outline and a plan on how to actually get started the writing on this. And we'll see you next time.
Thank you, everyone. Have a great day.